of you. This is a topic which I kept on request of all the students. Repeatedly, everybody been messaging, Sir, Euro-Onco is something which we are not strong, not well covered, and we get stuck both in theory and practicals. So please call an expert. There is only one person who came to my mind, and I know all over India it is my dear friend Dr. Yuvaraja, who is extremely proficient, highly qualified, dedicated uro-oncologist, not just an excellent surgeon with skill, but also concepts are very good. He is very well read and excellent teacher. I know he was extremely busy, but somehow it's his greatness. He could accommodate and give a date for us. And the topic, even though I gave certain guidelines, but he's going to cover it as a teaching session. Please utilize this particular opportunity extremely well. Because there's a lot that changed in last couple of years, and students invariably get stuck both in theory and practicals, and they don't perform the way it should be in this particular topic. So please go ahead and utilize it. And I wholeheartedly thank and welcome Yuvaraja for able to spare time for the benefit of our students. At the end of it, he will open Q&A chat box and answer whatever doubts possible in the time allotted. Thank you. Welcome. Over to you, Raj.
Thank you, Dr. Somsekhar. Thanks for your kind introduction, and thank DNB examination, Mr. Navneet G, for coordinating this. Very nice. So now, as Dr. Somsekhar told, so we will be going ahead with the discussion of bladder cancer. What you are supposed to know basics and little bit advanced. Once you know the basic, the advanced becomes quite easier. So I will cover in brief a little bit of theory, and then we will go into the practical aspects of that. If you have anything, any questions, you can. Yeah. So now, the outline of my talk will be epidemiology, etiology, staging, and the diagnosis, diagnostic modality, and investigations and management. Okay, so now bladder cancer, we know that it is becoming more and more common, and it has been, unfortunately, it is one of the cancer which is very highly, it affects survival, and but it's not managed very well in all the centers in the way it has to be, it should be managed. And it is the 7th most common diagnosed cancer in male, and in genitourinary, it is second one, next to prostate cancer. So mortality is very high. So that is the reason. So we are supposed to treat it very aggressively. It's an aggressive tumor which affects the survival. So if you see this, the 5-year survival related by stage 1. So when it becomes pretty muscle invasive, we have lost the battle. So our job is to identify and treat it as early as possible. And when it becomes when it is regional, almost 37% survival. We say it's almost 50% survival for 5 years if it is muscle invasive. That means it is a very aggressive tumor, and all the methods have been being applied to improve the survival in this cancer. So what exactly causes bladder cancer? Because this is one of the important questions, even in practical, even in theory, they ask. So I just give the outline. Genetic susceptibility, environmental factors always play in majority of the cancer. Most important is the smoking and tobacco and occupational exposure. These are the two things which we should remember. And smoking and tobacco increases the incidence of bladder cancer by 13-fold. So remember that when I say smoking and tobacco, it is urothelial cancer, starting from renal pelvis, ureter, bladder, and urethra. However, 90% of the cancers happens in the bladder, 8% in the upper tract, 2% in the urethra. Very easy to remember. So this is because the field effect of this the tobacco effect on the urothelial epithelium. So occupational exposure, we know that there are few occupations where are more prone to get, like leather industry, petrol industry, and so many of them. But it's very important when you get a case or when you have a theory, so you have to ask and write it, all these points. Dietary factors, radiations and medicines, again, one of the risk factor. So previously irradiated, pelvic irradiation by fascia cervicia rectum, RSEA prostate predisposes bladder 1.5 times more common than a normal individual. So that means we have known factors, and majority of the times it is unknown factors which plays a. So that means it's environmental genetic factors which we try to figure out. So smoking, as I told you, so you can see that this hazard ratio and occupational exposure, dye workers, chimney sweepers, even rubber workers, nurses. I don't know why, but I didn't go into detail. And these are the people who are at risk of getting bladder cancer. So for the students, if you want these slides, so don't write anything. You just listen. And in the end, I can share the slides with the coordinator. Then you can all the slides to study. Pathology. So when we this about the epidemiology and in brief, and if we go to the pathological aspect of cancer, so mainly it is a urothelial cancer. Remember, once I see here, so you can see I have written as the transitional cell carcinoma, although we commonly use it. So the current terminology is urothelial carcinoma. It's carcinoma in situ, and other types of urothelial carcinoma, squamous cell carcinoma, adenocarcinoma, anaplastic, and variant histology. Variant histology, I'll have one more slide because it is becoming more and more important now. But most important is that the transitional carcinoma, the type of urothelial carcinoma, very. So now, if you see variants, there are many. As I told you, urothelial carcinoma is 90%. Others are squamous and adenocarcinoma. These are all squamous per se, so primary and primary adenocarcinoma. And most important variety, if this is a very good short notes for DNB students, variant histology and their management. Because management is little different from the standard TCC. So micropapillary variant, then we have neuroendocrine variant. If you see the third one and the last one, these are the two most common varieties of variants of urothelial carcinoma. Are nested plasmacytoid and small cell carcinomas, these are the other ones. These are all very important because once it becomes variant histology, they are all aggressive tumors with much more poor prognostic factors. So that means what? We have to treat this with aggressive with both chemotherapy, surgery, and at sometimes we even the radiation therapy. So that means here there is no question of bladder preservation in variant histology because it's very difficult to do that, as we know that it's an aggressive tumor. That is the take-home message with variant histology. So then what is the clinical presentation? Clinical presentation, generally, when we say that it is asymptomatic in many, we can get, nowadays we are getting incident tumors because of routine executive health checkup and ultrasound imaging for other reasons. And then main presenting symptom, if they present, is the hematuria. The hematuria is always painless hematuria. Unless the patient has got retention of urine, then the patient will have a painful hematuria. That pain is due to distension of bladder. And then we have clots. If the presence of clots in the urine indicates significant bleeding and has to be evaluated. And of course, our hematuria, whether it is microscopic hematuria or a macroscopic hematuria, needs further investigation to rule out cause, because there will be some cause for microscopic hematuria. We don't get hematuria without a cause. And sometimes the patient just presented with the irritative voiding symptoms, possible. So any patient who has got a urinary symptom has to be investigated. So one of the DD will be in a history level will be bladder cancer. So then what are the further investigation we look into? So the further investigations are, the first one, when the patient comes, we get imaging, but just for the completion's sake, so we do urine cytology. So this is a theoretical way of writing this thing, but in the practical, when we get a case, the first will be the imaging and all other tests. So urine cytology comes along with that, and then it indicates urothelial specificity is almost if it is positive, 90 to 98% positive specificity. Sensitivity is quite less because all tumors will not shed tumor cells into the urine. So if they ask you in the examination, if you do a urine cytology, be very clear. So we do urine cytology to rule out high grade lesions, because high grade lesions will invariably have positive urine cytology. The yield is also good, but only thing is that good pathology is required because it is mixed with blood cells, especially lymphocytes, where you get confused. Urinary markers. So we do use it only for not for the initial diagnosis. Very rarely we use it. If it's inconclusive, generally we use it. That is NMP22 we use nowadays for regular surveillance after the superficial bladder cancer or the non-muscle invasive bladder cancer is treated. So the most commonest investigation after once you get this patient is ultrasonography, which shows five gross tumors and any other clots or hydronephrosis. All this information can get. And most important cross-sectional image is CT scan. So intravenous urography nowadays is almost don't do it. It is not in the guidelines. So CT scan, the contrast and CT scan with abdomen and pelvis is the standard investigation for bladder cancer. So nowadays MRI, that is MP MRI, multi-parametric MRI coming in a big way. But however, this had come earlier also. Now also it is there. So they do like a thyroid score for prostate cancer. They do cycle imaging and the reporting system, that is Virad score, which generally they try to say whether it is going to the muscle or not. However, remember Virad score is only, or MRI is only for theory, and for practical when the case is kept, we don't remove the bladder based only on MRI. So usually the biopsy is a must. It has not replaced biopsy at all. These basic investigations, we proceed to cystoscopy. It is the gold standard for diagnosis as well as treatment of bladder cancer. So now what we do is a white light cystoscopy. Nowadays there is an improvement in cystoscopy. However, we may not use it in the first setting unless we suspect only carcinoma in situ. That is blue light cystoscopy, as well as we have narrowband imaging. So these are the two things which are becoming more and more popular, especially for follow-up cystoscopy. So once we do cystoscopy, we can know the site size, number, appearance, and same time. So we do take a biopsy or we do complete TO. So as I told you, multiparametric MRI, this is one of the very good paper. Any Virad score of 3 or more is indicative of muscle invasiveness, and 4, 5 is definite. 3 becomes again borderline. 1 and 2 Virad score is non-muscle invasive bladder cancer. If you see this, show the picture. The above is a white light normal cystoscopy. You don't know whether this is a tumor or not. When you do a blue light cystoscopy, you can clearly see all the small tumors which are all pink in color. So you can really remove these lesions. So this is how it's very useful, and but it's quite expensive. So now we have urinary biomarkers. So as I told you, we use only NMP22. So this is one of the important, even a short note. So we assess the derivatives of malignant cells in the urine in the form of NMP22, Euro, PTA, and the sensitivity is quite low, and specificity is not as high as urine cytology, but for follow-up studies, it's quite useful. When you combine this one with the urine cytology, it becomes a non-invasive method. So guidelines, as far as whatever I told till now, everything is a strong recommendation. So these are the EAU guidelines, European Association of Urology, history, and then we have a computer, that is CT scan, so CT IVU, what they call, and then we have to have, the question is here is only one question they ask, whether you want to do CT scan before or after TURBT. So if you have a tumor which is seen on sonography, better to get a CT scan if the patient can afford it before doing TURBT, because it gives more information. False positive reporting of CT scan will not be there when you do it after TURBT. So cystoscopy, strong recommendation, and all the features what we get from cystoscopy and urine cytology. Many times, if his urine cytology is not, wadded urine cytology is not available, we do bladder wash cytology. So all these things will help you in diagnosis. So suppose if you see a big tumor in the bladder, you can see evidently there is a small tumor adjacent to the carcinoma. It may not be useful. But if there is a small tumor, you don't know whether it is a low-grade tumor or a high-grade tumor, then you take a cytology. If it is associated with carcinoma in bladder cancer is an aggressive disease. Carcinoma in situ should not be considered as a important disease. It's a very important disease, bladder cancer. Now we'll go to a little bit of the staging and how do we histologically classify them. I think we know all of you are aware of this one. Carcinoma in situ, TA is not invading into the basement, into the epithelium. And then we see when it invades the epithelium, basement membrane, goes into lamina propria, it becomes T1 lesion, goes to muscle, T2 superficial and deep, T3 is outside the muscle, goes into the fat, T4 is adjacent structure. Very easy to remember. So remember T1 lesion. So once you remember T1 into lamina propria, so then you know all other things is easy. However, this classification, especially the grading of the tumor, I'll come back with, although it's mentioned here, I'll come back to that in the next future. So new terminology. Now, remember, this is one of the important guidelines which has come from Uropathology Association. So earlier, when we used to do this grading of this tumor, that is a 1973 classification, grade 1, grade 2, grade 3. So all of us used to do it till 2011. Actually, although they came as WHO in 2004, in 2011 it came as WHO ISUP, International Society of Uropathology. What we use it right now is ISUP grading. So now this has been revisited, and if you see here, this graph is very easy to understand. Pun lump, that is, proliferation of urothelial epithelium of low malignant potential. So basically, we consider this as a benign tumor. Remember, earlier there was something called as papilloma. Papilloma terminology, we don't use it now, so we use it as pun lump. Remember that. And in pun lump, some amount of grade 1 tumors went inside because they found out that they behave like a benign tumors. No need to call it as cancer. Some grade 1 tumors went into low grade. Majority of the grade tumors went into low grade. Remember, grade 2 all now are called as low grade. Of the low grade tumors went into high grade. All high grade lesions went into, grade 3 lesion went into high grade. That means they redistributed grades into the grades. Grade 1 to 3 into low and high grade. So presently they report as pun lump, low grade, high grade, cancer, WHO ISO grading. This is the current grading system. So this picture is easy to understand. So now, another most important significant change took place was that when it is invading the muscle, we used to call it a superficial bladder cancer. But nowadays, we are not supposed to use it because it's still I'll go back to the previous slide. You can understand. It is invading the lamina propria, T1. So all TIS, TA, T1, these three combined together, they are called as non-muscle invasive bladder cancer. We should not call it as superficial because it misguides, and we think that it is not invading the lamina propria basement. That means there is something very important, but even for the T1 lead. So that is the recent advance which has taken place. I think TNM classification, all of you know. So it is basically T is very important. N, when it is a metastatic into the single node or multiple node, it becomes a stage 4 lesion. So that you can study. Treatment group, if you can see, is a non-muscle invasive, TIS, TA, T1, muscle invasive with T2, and N1 we consider it as now as 2, metastatic as M1, the metastatic in the liver and the.
Sorry to interrupt, Raj.
Yeah.
Can you just come closer and speak a bit louder?
Oh, okay. Fine. Now it's okay?
No.
The volume of this thing is also very high.
The volume is high, but we are not able to hear you. Can you just switch on the other laptop and use the audio from that?
So then,
but I think there's some problem with the audio of this laptop.
You have to keep it. So now, once as I told you, the terminology for non-muscle invasive bladder cancer, the basic step is transurethral resection of the bladder tumor, along with the adjuvant intravesical therapy. So these are the two important things for non-muscle invasive bladder cancer.
So TURBT, little brief. It's a generally it is a piecemeal technique. So we introduce the scope into the bladder and remove all these things. So although we can do an block with a laser treatment, but it's not advised. But anyhow, we are going to do the piecemeal to remove the tissue from the bladder. So the most important when we do TURBT or anybody does TURBT is that we have to remove the tumor as well as try to take the muscle biopsy. Very rarely it is not possible to take muscle biopsy because of a large vascular tumor. Otherwise, almost 90% of the times it is we are able to take the muscle. But when we take the muscle biopsy, the practical issue is that we have to take the muscle directly under the tumor. Invariably, what happens is that when you resect it, we don't know where was the center point of the tumor, because everything looks like okay, this was the tumor site. Then we take a muscle biopsy from away from the tumor, it won't give any information. So then that report of TURBT, we can see the size, tumor grade, depth of invasion, presence of CAS, detrusor muscle, everything we can make out from TURBT. So it is followed always by, now we have, I think as Dr. Somsekhar told, I would have put one study on this. So the standard treatment, when you do a TURBT and you think that it is not invading the muscle clinically, that is like during surgery, then immediate single post-operative installation of 80 milligram of mitomycin, 40 milligram of mitomycin is the treatment of choice. So we have to do within 6 hours after doing TURBT if there is no hematuria, gross hematuria. Then I think this video I'll skip it. This is the TURBT video. So I think you can see that. Okay, fine. So now you can see that once you go inside, these are all red areas. You can see that. So they're all looks like either early papillary or a carcinoma in situ lesions. So these are the solid looking tumor. You can see this is not a papillary tumor. It is a solid tumor. So yeah. So this is in the right trigonal area, right lateral wall. You can see that this is quite large tumor, multiple tumors all over the bladder. So these are the very aggressive tumor variety where you see solid tumor along with multiple tumors. So what we do it the resection. You can see that. So we can resect the entire tumor with the resector scope. This is how we do it. This is the tumor which we are removing it. Once we remove it, and then we have to go a little deeper. So deeper biopsy I will show you. Yeah, correct. So deeper biopsy. See, this is the deeper biopsy. I'm going very deep into the muscle, and this will give you the see now. So that is the detrusor muscle you can see here. This will give us all the information about the depth of invasion. That is the most important prognostic factor and planning the treatment. So now many times we do repeat TURBT. So this is required when. So when we do TURBT, the report comes as T1 tumor, high grade tumor. If there is an absence of muscle in the specimen or an incomplete resection based on the surgeon's finding, even for a T1 tumor, we have to do repeat TURBT. This is a normal, and it is now becoming a standard of care, because the current study says that when you do a re-TURBT, although you think that you have done a good job, upstaging to T2 is 25%, very, very high. That means we are under treating 25% of the patients by just an intravesical therapy, not a cystectomy. That means we are really harming these patients. And the next is residual tumor, although it may not upstage it 60%. Remember, the intravesical therapy will not act. It will not be useful if there is a gross tumor inside. It's only for prevention. It is not to treat the tumor. So that is the reason we should always have second biopsy. Random biopsies, so very rarely we do it. So when we suspect any carcinoma in situ, invisible, or when we want to do a neobladder, we would take a prostatic urethral biopsy. So otherwise we don't. So once we get a TURBT specimen, we group these people into 4 groups now. Little confusing. Earlier it was only 3 groups: low risk, high risk, and very high risk. So now there is a new group. This is very high risk. So this chart you have to go through because it is very difficult to understand it. But when we say that high risk group, it is always a carcinoma in situ T1 lesion and high grade lesion. In slash they have given grade 3 because some people still use grade 1, grade 2, grade 3. But T1 HG are a carcinoma in situ. Although you have removed everything, it is not muscle invasive. These are the group is called as high risk. Low risk tumors are all non-invasive, means TA tumors. Very few low-grade T1 lesions. All other tumors like multiple tumors, all those tumors come into intermediate risk. So remember, low risk TA lesion are a low-grade lesion, and a high-risk tumor T1 lesion, which is a high grade, or carcinoma in situ. All other tumors come into intermediate. They divide into high risk and very high risk that you can study in this slide. So then, what is the treatment recommendation based on this risk category? So we have low risk tumors. So definition, and only one installation is enough. As we have done mitomycin 40 milligram, that is enough for us. So we need not do any other treatment at all. Remember that. That means it is the end of the treatment and follow-up cystoscopy. No intravesical further treatment. Intermediate risk, the standard is BCG. Remember, standard is BCG. Others are known. I will tell you a little bit more about that one. High risk tumors, we have BCG plus maintenance. BCG plus maintenance. Maintenance means once in 3 months, we have to give 3 doses of BCG at the interval of 3, 6, 18 and 32. 18 and 36. Up to 3 years we have to give it. So there is a protocol. So this is called as which protocol? I just remember. It is a European protocol, and we have to give it up to 3 years. But the question is that maintenance BCG, many people don't tolerate it because BCG has got a lot of side effects. So another option for high risk tumors is a radical cystectomy. That means we are doing cystectomy even in high risk tumors, non-muscle invasive. Remember, select patients, which are then, they are the very high risk patients where we have a large solid tumor, high grade lesion, along with carcinoma in situ in other areas, concurrent carcinoma in situ. These are the people don't do well. That is the reason when you resect a tumor, always take a biopsy of surrounding areas to rule out carcinoma in situ. When there is a carcinoma in situ, it becomes a high risk tumor, very high risk tumor. Radical cystectomy should be considered. So these are the recommendations as of now. So remember, this chart is easy. So low risk, only one immediate installation. Intermediate BCG, high risk tumors are all either BCG with maintenance or we go for cystectomy. These are the two options. So intravesical therapy, immunotherapy, BCG. So this is quite commonly used, 120 milligram. If a patient cannot tolerate, you can use it 80 milligram. So chemotherapy agent most commonly used is mitomycin C. Nowadays we are using gemcitabine also. So these are the new things in intravesical therapy, what we call as electromagnetic drug administration or heated chemotherapy. So heated chemotherapy, so this is becoming much more common, which we also do it. So heated mitomycin, we put it into the bladder through a device. So with better results. So this is for low grade, low risk and intermediate risk, and even select case of high risk tumors. So these are the newer advances in device assisted therapy. So BCG, as I told you, so it's weekly for 6 weeks, 50 ml saline. Everybody should do it. Even everybody can do this. It's a simple OPD procedure. You start after 2 weeks from the tumor resection. Generally 3 weeks is better because because side effects are less. Maintenance as a SWOG protocol, that is 3, 6, 12, 18, 24, 30 and 36 months. Complete remissions we see in 70%. And so every 3 months after that, thereafter you have to do surveillance. So BCG failure. So this is again a very important theory question. Very rarely they may ask you in practicals. In urological DNB MC, they always ask this one. BCG refractory, relapsing, unresponsive. Because there was a lot of confusion here. So they made it only into 4 groups. Refractory means persistent disease. Relapsing means it complete during a maintenance BCG you will get a BCG failure of the tumor. Unresponsive, that means even after completion of BCG maintenance despite an initial response. So again the patient develops BCG intolerance is side effects of BCG. So there is no response. So little difficult to understand in one go. Go and this chart is available everywhere. Remember these terminologies, they are asked. So BCG failures. How do you treat BCG failures? Do a cystectomy, or we can go for bladder preserving strategies. Or second, intravesical chemotherapy is either mitomycin or gemcitabine. Remember, most important here is that when you have a BCG failure or when you have a high grade lesion, which is a very high risk, we are doing cystectomy without muscle invasion. So don't stick to that strict criteria of muscle invasion always. And in the same time, don't remove the bladder for low risk tumors. So this is what you have to learn. So these slides tell you all these things. Cystectomy, even sometimes without proving muscle invasion by TURBT. High risk, as I told you, very high risk group, BCG failures, prostatic urethral involvement with a high grade tumor is an indication for cystectomy because it's very difficult to clear the tumors here. Hydronephrosis, tumor at difficult site to resect. Large tumor in the anterior wall, difficult to resect. Maybe an intermediate risk, say, or a low grade tumor, but very difficult. Or a large tumor, you can't do. Or multiple tumors, entire bladder. So we can't remove the entire bladder mucosa. We have to do cystectomy. So there are, and variant histology, as I told you earlier. And a small capacity bladder, a small tumor. But anyhow, the patient is horrible, asymptom-wise. I think cystectomy is recommended. So so these are the most important points you have to know. Cystectomy without proving muscle invasion. Follow-up 3 monthly. So this everybody knows. So with cystoscopy and cytology must, with or without NMP22. So muscle invasive bladder cancer. This becomes T2, stage 2 tumor, and T3, minimally, outside is T3A and T3B is gross extravesical component. Radical cystectomy along with pelvic lymphadenectomy is the standard of care. So remember that. So now it's the gold standard. Complication rate is around 17 to 32%. It's a very high end surgery. And now the mortality has come down to 2%. So now it's 1% with minimally invasive. So quite lot of improvement even here. So this is the algorithm for MIBC treatment you can see here. So selective bladder preservation, radical cystectomy, and all these patients, so they are all medically operable. Along with that, so we have to have systemic chemotherapy. Can I just come back in 1 minute because there is some problem here?
Yeah, sure. Please come back.
Yeah, there is some issues going on here. Just I'll come back.
Okay. Michael, please read about it. These are some of the very, very important things which are very important. And at the end of it, you can ask all these questions to Dr. Yuvraj. So the concept needs to be very, very important. Third thing, everywhere currently, you know that in oncology, this is an era of not maximum tolerable treatment, but minimum effective treatment, maintaining a physiology, organ preservation. So this is an organ preservation protocol. Almost in the body, everywhere you have organ preservation. Hypopharynx, larynx, we give neoadjuvant chemoradiation and then try to preserve. If you see the sphincter, you try to do neoadjuvant concomitant chemoradiation, reduce the margin required, and we do. So ask the question at the end of it, Yuvaraja, the role of organ preservation. Okay? Thank you. Welcome back, Yuvraj. You're back. Over to you.
Can you see something?
You have to share the screen, sir.
And just hold on, there is a problem. Yeah. So now, as I told you, the standard treatment is radical cystectomy. So now we have multimodal therapy. So we'll come to that little later. So in men, it is radical cystectomy. This was the standard. So it includes removal of bladder, prostate, along with the perivesical fat and seminal vesicles. So in females, it includes ovaries, uterus, and cervix. We do what we call as anterior exentration. So generally, when to do radical cystectomy? So there is a controversy because now we are introducing neoadjuvant chemotherapy. So it was assumed that when we were doing a radical cystectomy upfront, we should not wait for more than 6 weeks, and preferably, and maximum is 3 months after TURBT. So even after chemotherapy now, so the same rule applies. After chemotherapy, we should not wait more than 6 weeks for cystectomy because it has got a decreased survival. So now the systemic therapy came into existence because, so what happened was that muscle invasive bladder cancer, the survival is only 50%. That means the patient used to fail mainly in the distant sites, liver, lung. That means there is a micromets from the beginning. So we used to undertreat it. So there were a lot of studies, neoadjuvant as well as adjuvant. Earlier, the Skinner group from USC, University of Southern California, main propaganda for adjuvant therapy. It was a standard. Now also they do the adjuvant therapy. But now in 2005 or 6, the major trials came for neoadjuvant, where the chemotherapy is given before cystectomy, and then we do cystectomy. So now the current is this is the standard. There are few studies, SWOG trial and ABC analysis. These are the two things you have to remember. SWOG trial and ABC analysis, advanced bladder cancer analysis, that is a meta-analysis. So I'll just have, I think I have a slide for that. So we know that why do we give chemotherapy in a neoadjuvant setting? This applies to everywhere in all cancers. So NSET improves 5-year survival by 5 to 8%. So this is ABC meta-analysis in Lancet 2003. Remember that. So clearly 5% benefit is a huge benefit because it is an absolute benefit. So if you see, compare into a a breast cancer or a colon cancer, maybe 1 to 2%, but it has become a standard of care. Similarly here, so as urologist, lot of resistance from the group, but now over a period of time, it has increased now. I think 33% in decrease in the risk of death is very huge. I think now presently neoadjuvant chemotherapy is a standard of care. So this is the trial, earlier trial. So you can see that. So with the control, earlier they used to use MVAC chemotherapy. Now also the many institutes use MVAC because this is the only which is used. So now they are changing to gemcitabine and cisplatin. So gemcitabine has been added. Actually, gemcitabine has never tested in a neoadjuvant setting, but because it is worked in metastatic CA bladder, they extrapolate the data and then they give gemcitabine cisplatin even for muscle invasive bladder cancer. So this is the study you have to remember. So with a 43 and 74 months median survival difference, it's a huge difference. And then we have these are the other trials studies. So MRC trial, earlier they came out with a 7-year follow-up, statistically significant benefit with neoadjuvant chemotherapy. And the last one you remember, European Urology 2005, ABC meta-analysis, improved overall survival by 5%, risk of death decreases by 14%. So this ABC meta-analysis completely changed the understanding and it became into all the guidelines. However, the acceptance was quite low. If you see here, I'll just tell that acceptance a little later. Then, does all patients receive chemotherapy? There is a selection here. If you see the last line, only 50% of your patients will be eligible for cisplatin. Remember, if it is a neoadjuvant chemotherapy, it is always cisplatin, no carboplatin here. If the patient is cisplatin ineligible, they go for upfront surgery or they can go for immunotherapy, which is coming up in a big way now. So GFR is very important. If it is less than 50, you are not supposed to give cisplatin. And if the patient has got a hearing loss, it increases because of neuropathy. And functional status ECOG should be 0 to 1. That means you have to choose the patients. In our patient setting, the 50% are eligible for cisplatin. In this eligible, only around 25 to 30% of these people go for cisplatin because other people refuse chemotherapy in the earlier setting. But this has to be offered in this setting. So what we give, Gemcite, Cisplat, Gemcite 1000 milligram per meter square. I think for a surgical oncology resident, this is required. And Cisplatin 70 milligram per meter square on day 2. Day 185 is the Gemcite. This is the standard regimen what we use. And MVAC regimen rarely used. Now they do because of the side effects. So now they do what is called as dose dense MVAC, DD-MVAC. There are certain institutes use it, dose dense MVAC, to reduce the period of chemotherapy. The reason was that Gemcite Cisplatin, we are waiting for 4 months for cystectomy. So there was a huge lot of problems with that. So that's the reason to decrease the duration to 2 months, they did DD-MVAC therapy. So now current recommendation, as I told you, there is no role of pre-operative radiation therapy. Many people still use it in centers where radiation is the predominant way of managing these tumors. There is no, so here there is a clear guideline. There is no pre-operative radiation therapy, and neoadjuvant chemotherapy, strong recommendation. And if they are not eligible, don't give NAC at all. Not eligible for cisplatin. So immunotherapy came in a big way because the chemotherapy had a lot of limitations, acceptance from the group. So if I remember, in 2011, the acceptance was only 13% in US. And now, luckily, it is almost 50% of the urologists agree with neoadjuvant chemotherapy and advise patients. So immunotherapy, there is a immune checkpoint inhibitors. These are the new things which is coming up in a very, very big way. And I think it's a very good question for you people, theoretical question for bladder cancer, immunotherapy in systemic immunotherapy in advanced bladder cancer. So now there are many trials with pembrolizumab, nivolumab. Every molecule has shown a promise. I think this will be the future. Future will be not chemotherapy, immunotherapy followed by surgery, or surgery followed by immunotherapy. There are 2 trials even for adjuvant studies. So I told you already this recommendation. So now this is the trial. This is what we call it as a checkmate trial 274, which says that nivolumab is better than placebo in an adjuvant setting. Remember, here the only problem is they didn't use the standard chemotherapy as a comparing arm. So nivolumab has become one of the accepted molecule in adjuvant setting. So then how to do the surgery? So radical cystoprostatectomy, whether you can do open or minimally invasive, either laparoscopic, robotic. Choice is yours and the patient's. So remember that all have got their own advantages, disadvantages. Preparations, little bit, I think all of you know that. Only thing is that, so what we do is fast track surgery. That means we don't do any the standard preparation. So we do ERAS protocol now. So that is the reason. The standard ERAS surgical protocol, we do it in all cystectomy. So, however, according to the patient general condition, you can modify accordingly. So, robotic lab, we have limitation with laparoscopic surgery, long learning curve. So, robotic has taken away all those things, are becoming second most common method used. So, after open surgery is still the gold standard for cystectomy. So, we compared robot versus open in a randomized way. So, this is called as a razor trial. The conclusion is that robotic RCAC was not inferior oncological to open RCAC. So, we have to prove first its oncological equality, and then we can prove that advantages. However, the blood transfusion rate and the recovery was better with robotic. All other parameters were not that much different in this trial. So always cystectomy is associated with bilateral pelvic lymph node dissection, so which we classify into level 1, 2, 3. So level 1 and 2 is required. Say up to the bifurcation of common iliacs is always we do this one, but we don't do a super extended one. So we do just a extended one, include all the nodes along the common iliac artery, and this is the extended pelvic lymph node dissection. Super extended is when we go to the aorta and para-aortic nodes. We don't do that because that doesn't, as shown in randomized trial, it has not shown any survival benefit. So extended versus limited. So there is a proof that it has got advantage, although it is not survival advantage, but we can group them and we can offer them adjuvant therapies based on these this thing. So urinary diversion, we know that we two commonest one, ileal conduit and neobladder, based on the patient condition, and most important, you have to the presence of the tumor. If it is in the prostatic urethra, no neobladder, and renal function. If it is serum, creatinine clearance less than 60, we are not supposed to do neobladder. These are the two contraindication for neobladder, apart from other relative contraindications. I think I need not go into the complications, but metabolic complications of any urinary diversion is a big question. So we have to monitor for these patients regularly, whether it is ideal conduit or neobladder. Neobladder more prone to get it. Ideal conduit, if you use a long segment, still the patient develops metabolic complications. So now Other treatments in a muscle invasive bladder cancer. So the standard treatment is neoadjuvant chemotherapy followed by surgery. Can we preserve the bladder? So it is possible. Bladder preservation, what we call it, is trimodal treatment: radical TURBT, chemotherapy, and radiation. Either sometimes they use only chemotherapy alone, not advised. Radiation is a part and parcel of bladder preservation. Coming up in a big way, but still patient selection is a very, very important. Not all patients will suitable for this one. So now this is the trial, trimodal approach. This is the study. So by Smith et al., bladder preservation in MIBC. Chemoradiation therapy is the most strongly supported one. Nowadays it is in the guideline. So a patient who is eligible for bladder preservation should be given an option of bladder preservation trimodal approach. That is radical TURBT, radiation, and chemotherapy. Many times they use concomitant chemotherapy and radiation. Some people use radiation followed by chemotherapy. So here you can see that maximal TURBT, radiation to full dose, concurrent chemotherapy, and then keep on assessing. So the chances of bladder preservation is to the tune of 50 to 70%. Still 30 to 50% may require cystectomy later on. So partial cystectomy, very rarely. Dome tumors, no other tumors in the bladder, no carcinoma in situ, only dome tumors where you can do partial cystectomy with bilateral pelvic lymph node dissection. Select patients. Not much about metastatic bladder cancer, but still 10 to 15% at diagnosis you have metastasis. The standard therapy is platinum eligible, is cisplatin and gemcitabine. So DDMVAC, you can give that. Carboplatin, if it is there, cisplatin ineligible, or we can go for PDL1 and PDL expression and immunotherapy. So these are the three things you have to remember: cisplatin, just cisplatin, carboplatin, carbogem, or platin ineligible. You can also go for immunotherapy. Very expensive, but still this is one of the treatment available. So only one word, I like this picture for all postgraduates. A lot of confusion in PDL1, how it looks and how it. So always I wanted to tell this. This is the T cell. This is the tumor cell. PDL1 is with the tumor. PD1 is with the T cell. These two combine, join, and then make this T cell immune deficient in its function. What we have to block? Either we have to block PD1 or PDL1. PD1 is blocked by pembrolizumab. PDL1 is blocked by atezolizumab. That's all. So we have to block either PD1 or PDL1 to make T cell not to be affected by tumor cell. So this is the basics of PDN and PDL1 pathway, and this is becoming a big way in many cancers and bladder cancer in urology. So there are a lot of trials going on and published. So this is the list of trials, and with a significant better survival. So this is about in brief about managing how we manage bladder cancer. Thank you so much. Any questions you can ask now.
Thank you very much, Yuvaraja. Excellent talk, and very nicely you analyzed, and a lot of excellent trials you put it. There are a lot of questions in the chat box. Will you open that? Are you able to? Yeah.
The first question is quite a lot of time. TURBT specimen shows no muscle specimen, especially large bulky tumor. As I told you, so urologist is the person who does the cystoscopy is the most important person. If it is a large bulky tumor, invariably even an MRI and CT scan, you can see the muscle invasion or a extravesical component. You need not try hard to get it only muscle, because it's difficult, because it bleeds. So you can mention it's a large unresectable tumor. The patient is candidate for cystectomy. The next question is neoadjuvant chemotherapy. Is it mandatory to prove muscle invasion histologically? We try to prove that. As I told you, in a large tumor, extravesical component or lymph node metastasis, there is no need to prove that. So we have, try to do that if it is possible technically. If technically not possible, we have to mention it. It is technically not possible. Go ahead, no problem at all. Advanced bladder cancer with ureteric obstruction causing adenovirus, how to proceed? It's a very, very, very valid point here. Many times what happens is that these patients have a adenovirus and serum create less. So that we think that they are not eligible for neoadjuvant chemotherapy. So we have to de-obstruct it. So what we do is that we do a antegrade stenting, because the stenting from below is invariably not possible. Either we do antegrade stenting or we do a PCR. make the patient stabilize creatinine-wise and reassess the creatinine clearance. If they are for chemotherapy, we send for chemotherapy. Still, if they are in a creatinine is a higher side or a low creatinine clearance, we'll go for surgery. So majority of this patient with hydronephrosis is generally contraindication for bladder preservation. Remember, bladder preservation, tumor should be resected completely. Number two, there should not be a hydronephrosis, which is not a good thing because very difficult to treat these patients. And there should not be a carcinoma in situ. Carcinoma in situ, bladder preservation is not that good. So these are the criteria. Okay.
There is one question. Can you please let us know the BCG response to tumor and classification, relapse and recurrences comparing BCG MMC?
See, BCG, what is the first part? The dose.
Response rates.
Response rate is 70 to 80% response rates. That means it prevents recurrences to the tune of 70 to 80% and progression to T2 in 13 to 20%. So progression prevention is quite less, but still, so as it is a superficial tumor, patient is under surveillance under us. We can still do a cystoscopy every 3 months and cross-sectional imaging, and I think we'll be able to do that. And what is the second part of the question?
Means MMC, intravesical MMC versus BCG.
Yeah. So MMC generally it is not for a high grade, high risk tumors. It is for a intermediate risk tumors and low risk tumors. So in MMC, in a high risk tumors is only generally now there are 2 studies which say that heated mitomycin, that is high-vac therapy, is better than mitomycin alone. We give this mitomycin only if it is a BCG intolerant patients where BCG lot of side effects, we cannot give it, then only we give it. So other molecules which we use is gemcitabine regularly.
There is another question. What should be the interval between 2 TURBTs? When we need to do re-TURBT?
Yeah. So again, this question has been, there is no standard protocol for that. Usually you wait for 1 to 2 weeks, not more than that. There is no meaning in waiting for 3 weeks, 4 weeks, because re-TURBT is quite easy. It's not because you already removed the gross tumor. Only the remaining raw surface has to be excised. So there is no time frame for that. But generally we wait for 1 to 2 weeks for the patient to recover, and we can go ahead.
There is one more question, sir. What exactly do we mean by presacral nodes? Do we routinely remove them in a radical cystectomy?
So presacral node, there are 2 groups, again 2 school of thought. The European group always remove the presacral node. That presacral node exactly is not in front of the sacrum. It is in front of the ala of the sacrum, medial to the internal iliac artery onto the sacrum and medial to the common iliac artery. So these are the areas to be cleared. These are all the presacral regions. If you think that there are nodes in that area, you can do that. But we generally do that in radical cystectomy, which gives us more information. And there are few studies which say that there are a lot of patients who will be presacral node positivity. Although we don't know the survival benefit of entire pelvic lymph node dissection, but as an oncologist, I think a good lymph node dissection is a must for bladder cancer.
Is there any role of PET-CT in management of bladder cancer?
Yeah. So as far as guidelines goes, even in Western countries, so not for primary diagnosis, for the lymph node and metastatic, especially in the follow-up period, there is a role of PET-CT, not for the initial diagnosis. However, we know that in India, many people get it done. That is a different question altogether.
There is another question. While doing a TURBT, bladder perforation happens. Is that a straight indication for surgery now?
No. Again, when the bladder perforation happens, you have to classify many things. Whether you have removed the complete tumor, are you dealing with a suspected muscle invasive tumor, or if there is a perforation with bleeding, without bleeding. There is a perforation, doesn't matter, without bleeding, because generally intraperitoneal perforation is very rare. It is always extra vesical but extra peritoneal also. So no need to do that. Although there's theoretical possibility of implanting these cells into the extraperitoneal, but doesn't translate always into a tumor recurrences. You treat it like what you are treated for the primary diagnosis. So many times we put a SPC or we put drain in the extraperitoneal space, put a catheter, we come out if there is no bleeding.
Sir, kindly can you elaborate bladder preservation protocol which you told concomitant chemo RT and observation? In which cases and when should we use it?
Yeah, the bladder preservation protocol, if you follow it, forget about the patient who refused surgery or were not eligible for surgery. We are going to do that. Yeah. But for the patients who are eligible for all the treatment, whom do we choose? Number one, preferably T2 tumors on imaging, not T3 tumors. T3A is okay, but gross extravesical extension doesn't affect. TURBT wise, you are able to remove the entire visible tumor. Residual tumor, they don't do well. Absence of carcinoma in situ, extensive carcinoma in situ in the bladder, and then absence of hydronephrosis. These are the classical indications for bladder preservation, where we think that we can preserve to the tune of 50 to 70%. The protocol, you do TURBT. After 1 to 2 weeks, the patient will go for chemoradiation. We do give concurrent chemoradiation. So that the entire procedure takes place almost 1 or 2 months, and then we do a cystoscopy after 1 month of finishing the surgery of chemoradiation, and see the imaging as well as the CT scan as well as cystoscopy, and we try to take the biopsy if there is any tumor. If there is not responding, straight away the patient goes for surgery. So this is the protocol generally followed for bladder preservation. So that is trimodal treatment.
Thank you very much. You had a lot of questions still there, but I think every good thing has to come to an end. Beautifully, comprehensively, you covered to the tune of Uro-Onco fellowship.
Very difficult to cover in 1 hour.
No, but beautifully covered. Fantastic concept. I always tell our DNB student, our job is not to spoon feed at this level. Our job is to show the direction and stimulate their brain and the direction, and then they have to walk and read more on that. You did more than that. Thank you very much. My wholehearted thanks on behalf of NBE, DNB board, myself and all the students. Thank you very much for this effort. Beautiful talk, and we really learned a lot. Thanks, and have a nice day, please.
Thank you so much, Somsekhar. Thank you. Bye.